So when we say eyeball has a three coats, right? It has a three coat. One is outer layer is fibrous, then the middle layer of vascular, then the inner layer, that is the nervous coat. So there's the outer layer of the fibrous coat. So outer layer of fibrous coat, this is called sclera, and this sclera is continuous. It is continuous with a transparent membrane at the front. This is called cornea. Okay, so this is the outermost layer of the eyeball, sclera and the cornea. Then in the middle there is a vascular coat, highly vascular, that contains of the blood vessels. This is the choroid. Okay. So as this choroid goes towards the anterior side, it is continuous as the ciliary body and then iris. Okay. So this is the second layer. This is the vascular coat, highly vascular, and as it goes towards the anterior side, it makes this is called ciliary body, and it continues with the iris. Okay, so this is called iris and this is called ciliary body. So this is the middle layer. Okay, this is the middle layer. Then there is the innermost layer which contains the optic nerve, that is the second nerve. Okay, it contains this is the nervous coat, and this is the retina. So this optic nerve and is the retina. Okay, so this is the retina. So this ciliary body, it has got some strings which are called zonules. So these zonules will hold the lens here. Okay. It will hold the lens. So this ciliary body will hold the lens. So this is the lens. Okay, so what are the parts of the eyeball from outside to inside? The sclera continues with the cornea, which is a transparent membrane. Then this is the iris, ciliary body, and the choroid is the highly vascular tissues. And then there is the optic nerve fiber. This is the retina. Okay, this retina has got a 10 layers. Okay, we are not going to the 10 layers, but from outside to inside, it has you have to know this part because it has got a cuboidal epithelial cells. It's a single layer of pigment epithelium. Single layer of pigment epithelium. Why this is important? Because this pigment epithelium nourishes the photoreceptors. Okay, so this is the single layer of pigment epithelium right at the back of the retina, at the front of the choroid. And here there is the photoreceptor, layer of photoreceptors. So there are two types of photoreceptors in our eye. One is called, which is rod shaped. So they are called rods. Another is cone shaped. So they are called cones. Rods and cones. Okay. The rods are necessary for our dim vision, dim light. Remember, dim light. They work mainly in the dim light, and they are especially wanted for black and white vision. They are for black and white. And they work mostly in the dim light when the light is down. The cones, they are for color vision. Color vision. Okay, we see the colors because of the cones, and they work basically in the bright light, in the daylight. Okay, these are the features. So where these rods and cones are present? These rods and cones are present exactly above this pigment epithelial cell layer. Okay, here they are the rods and cones. Rods and cones. Rods and cones. Okay. In the retina, there is also one point here. There is a small dent here, which is called macula lutea, which is it's a little bit yellowish in color, and there is a little bit dent here. and this is called macula lutea. Macula lutea. Okay, so when the light falls and when the image is formed over the macula lutea, we get the sharpest vision. We get the sharpest vision because here in the macula lutea there is the center here. This is called fovea centralis. This is called fovea centralis, which is highly concentrated with cones. Fovea centralis. This fovea centralis in the macula lutea is highly concentrated in cones. So when the image is formed and the light falls on the retina, when it falls on the fovea centralis, we get the sharpest vision, we get the most clear vision. Okay, it is necessary because when we see something, okay, the central vision should be clear rather than the outside, rather than the periphery. When you see in the straight, the central part of our field of vision should be more clear than the outside. So that is because of the fovea centralis located in the macula lutea, which is very much concentrated in cones, and because of that, it gives a high HD vision, you can say, high definition vision when the image is formed here. Okay. So these rods and cones, they are connected with some cells which are called bipolar cells. Okay, bipolar means two poles, bipolar cells. And these bipolar cells and then connected to, okay, I'm not going in so much detail, but you have to know a little bit of physiology here. These bipolar cells are then connected to ganglion cells. Okay, I'm just drawing one side, okay, not the both side. Okay, these are called ganglion cells. So from these ganglion cells, there are some loose wires, or what we call axons. Okay, from these ganglion cells, the axons move. The axons, they collectively go towards this tunnel from both sides. Okay, these axons. So where these axons comes out from? The axons comes out from the ganglion cells. Okay. So, and they move out of this tunnel. So all this collection of wires coming out of the ganglion cells, this is called optic nerve. Okay. So what I am trying to say here, that when the light falls, when the light comes from outside, it falls on the pigment epithelium, then these rods and cones will be activated. There will be some chemical changes. We will discuss that thing later. There will be some chemical change which will stimulate these bipolar cells. This is bipolar cells. Then these bipolar cells will activate these ganglion cells. It will activate these ganglion cells, and then this whole image is passed through these axons, and collectively they go out of this eyeball, and we call this optic nerve. Where it goes? It goes to the occipital lobe. Okay, it goes to the occipital lobe. So in regards to the anatomy of the eyeball, you have to know there are three coating. Yes, we know the sclera and the choroid. Middle coat, vascular coat. Okay, so sclera at the cornea, middle is the choroid, ciliary body, iris. Then innermost coat, the nervous tissue. That is the retina, which has got 10 layers, along with the optic nerve fibers and along with this pigment epithelium, along with the cells, which together will form the nervous tissue. Okay, along with that, what else is here? So this aperture between this gap, between these two iris, this gap is called pupil. It is called as pupil. This is called pupil. And outside from here, okay, there is a thin fold called conjunctiva. Yeah, it's a fold. It folds upon itself. Okay, and this is the eyelashes. These are the eyelashes. So this is conjunctiva. Okay, so when the light falls, so when the light comes from any image, okay, this is the object. That is an object. Okay, so when the light falls on the object and it bounces towards our eyes, then only we can see. That's why we cannot see anything in the dark. So light must fall to this object, and from here it must bounce to our eyes. So first which layer it crossed? It crossed the layer of the cornea. It first reached the cornea. And cornea is that transparent membrane which is got refractory power. It bends the rays of the light. So when the rays of the light comes from the image, this cornea, it will bend the rays of the light towards the lens. So 75% of the bending is done by the cornea itself. Then 25% of the bending of the light is done by the lens. Then finally this lens will bend this rays towards one point in somewhere in retina. It will, okay, let me remove the whole layers here, and all this ray of light is finally put into one point. And when it is put into one point, we can see the image. If it is being distorted everywhere, then we will see all the whole image is broken down into pieces. Okay, it is finally put down into one point. So 75% is bent by the rays of the light is bent down by the cornea, 25% is bent down by the lens, and then finally it is put in retina in one point. That is very important. And remember, the image that is here in the retina, the image is formed in inverted image. Image is in inverted form. Then this inverted image is sent to the brain, and our brain do the correction. It again, occipital lobe, again it reverses it. Okay, so the image that is here formed, it is in inverted form. Then finally the occipital lobe, it correct it again, make it correct. Okay, now it can ask me a question that what will happen if the object is somewhere. Suppose the object is here instead of here in the center, the object is here in the side. What will happen if the object is in the side? Okay, let's see. So suppose the rays are coming from this way, and it's bent by the cornea, it bent by the lens, and suppose this lens has bended these rays of light to such a point that the image is forming here. Now there is a gap here. You can see this is the mass gap in this is a hollow tunnel in the eyeball, because it's a gap from where the optic nerve passed through. And if the image is formed here, then there is no retina here. Remember, there is no retina. So if the image is formed here, we cannot see that image. That is called the blind spot of the eye. That is called blind spot of the eye. Okay, in both of our eyes we have a blind spot. Like for example, if I say this is one object, okay, let me write a letter A, and this is letter B. Okay, now if I go towards the A with one eye closed, and at one point when I go close to that point, when I'm looking at when I fix my eyeball, when I fix my gaze into that A and going close to it, at one point this A will disappear. At one point, the point where it disappears, that point is called blind spot. Everybody has a blind spot. That's just, and remember, this blind spot is in both the eyes. So sometimes it is usually at this angle. Okay, when you see something straight, something at little bit of this distance, it is a blind spot. Okay, we don't see anything image. So that's why if you're driving a car, you are in a junction, sometimes a car in that point you may not be able to see, because it is falling on the blind spot. That's how the accident occurs in the junction. Sometimes the car disappears because it is falling in the blind spot. Now the question is that if the image is there, then we should be able to, we can't see any image, then why don't we see some black dot? Whenever we have a view, why don't we see one black dot here and one black dot here? Because there is a blind spot here. Okay, the question is that why there is no black spot in our field of vision. So whatever you are looking at, you are looking this vision, okay, why there is one black spot for my right eye, one black spot for left eye? Because the image is something, when the rays are coming from this point, is falling here. Now this is also photoshopped by our brain. Okay, there is a black spot, but our brain is just photoshop it so that our vision don't look ugly. Okay, that is the reason we don't. Yes, we have a blind spot, but we don't see any black spot normally in our field of vision. Otherwise, it will be so difficult. You are looking at, you see one black spot here, one black spot here every time. Okay, so that black spot is again Photoshop. It is just removed by our brain and put a nice background. to correlate with the environment. Okay, so that is about the anatomy of the eyeball. Apart from that, what else here? Yes, lens, anything I missed? Okay, there's more to be discussed now. Okay, now we are going to the, after the anatomy of the eye, we are going to the refractory errors. Refractory errors. So there are 4 types of refractory errors. One is presbyopia. Second is myopia. Third is hypermetropia. And fourth is astigmatism. So there are 4 types of refractory errors. Now let's go one by one. Okay, let's say this is an eyeball. Okay, and that's an image. That's an image. Okay. Now, normally, when the ray of this object, parallel rays of light, it comes. Okay. Let me draw the lens. Just a simplified version. Huh? So when these parallel rays of light are coming from a distant object, so they are bent by the cornea. They are bent by the cornea, and these rays are further bent down by the lens, and they fall into one plane, one point, and the image is formed. So this is called emmetropic eye, means it's normal eye. Emmetropic eye. Okay, when parallel rays of light coming from a distant source are bent by the cornea and lens, and finally is falling on the retina on a single point, and the image is clear and normal. It is called emmetropic eye. Okay, but every time it don't happen. Now imagine a person who is continuously working on small things like a watchmaker, or take your examples, continuously you are watching the phone, you are watching the tablets, watching any near distant work, near vision, near works. Okay, constantly reading, writing, watching. So you are using your eyes in a near vision, or people who mostly stay indoors rather than going outdoors. Okay, they are all at a risk factor. Sometimes what happens, this eyeball, now imagine, this eyeball is, it has gone bigger, it has elongated. Okay, let me make this eyeball bigger now. Now what will happen, this eyeball becomes bigger. Now suppose this eyeball becomes bigger. Now what will happen? The ray of light is focusing on in the front of the retina, not over the retina. So now the image will be, what happened? Image is blurred, because the ray of light coming from the object is not falling over the retina, it's falling in the front of retina. So when a ray of light falls in the front of retina, not in the retina, this disease is called, this refractory error is called myopia. Okay, myopia means short-sightedness. Short-sightedness. So these are those people who can see clear things when it is near, but they cannot see things clear when it is far away. Like me also. I can see things which are near to me, but when I have to drive, when I have to go out, I see every face is blurred, because I cannot see anything far. That's why I'm wearing these glasses. Okay, so I am having myopia. Or if you can't see the blackboard or whiteboard, you are having myopia. So myopia means short-sightedness, means one who can see things that are at close, but not when it is far away. Okay, myopia. If you have any doubt, you can always stop me and interrupt me and ask me questions. So this is one disease. This is one refractory error. Okay, so who are the people they are having myopia? So diabetes is one of the risk factors, and as I told you, those people who are having risk factors are mostly those kids or people who mostly prefer to stay indoors, means avoiding of the daylight. When you are not using daylight and mostly using the indoor lights, then due to environmental condition, due to genetic condition, there may be some elongation of the eyeball. Plus, due to professional workers like watch workers or who working in microscopes, watches, they are also having this type of defect. Okay, though we don't know the exact defect, but these are also risk factors. And what else? And when the bending power, means the convergence power of this what is called, the cornea and the lens, when the convergence power is increased, sometimes this eyeball is not elongated, it is of the same size, it's not become big, but this lens and the cornea, their convergence power becomes increased, so they converge before the retina. So there can be two factors, either elongation of eyeball, or there is increased convergence power or refractory power of the lens and cornea. Okay, so that is called myopia. Now what is the treatment? If I go and tell my doctor I am having an optician that I am having a myopia, what will he give me? Obviously he will give me that type of lens that will diverge the lens little bit so that the rays reach here. So he will give me one concave lens. So when I am using concave lens, these rays will be now little bit diverted, so that they fall in the one point. Okay, so the treatment is, what is the treatment? Concave lens. If you have any doubt, you can ask me. Okay, the treatment of the myopia is concave lens. Okay, going to the next is hypermetropia. Okay, so here this is the object, and here the ray, this is the lens, and the ray of the light is coming, the parallel rays of light coming here, and is bent by the cornea, bent by the lens, and it is falling here. It is falling here, behind the retina. The point of the convergence point, the focus is falling behind the retina, not at the retina. This is called hypermetropia or far-sightedness. Far-sightedness. So far-sightedness or hypermetropia means people who can see things clear in the far, but for reading they need glasses. For near vision they need glasses. They can't see anything that is clear at around 10 centimeter. Okay, they can't see things clear like reading books, okay, doing near works, watching phone also. They can't see clear, it's blurred because they are having hypermetropia. Means the lens, the cornea have lost their bending power. They lost their refractory power. As a result, rays are falling behind the retina. This is called hypermetropia. Okay, this same condition, hypermetropia, also occurs in old age, because in old, as we go aging, as you do aging, the lens lose its capacity, because this lens is held by the ciliary muscles, you know that, to the ciliary body, and this lens becomes oval and circular according to the distance of the object. So our lens accommodate, it adjusts. So suddenly you are watching the distance, and suddenly if you watch, then our lens changes its shape from oval to spherical and becomes flat whenever it needs more convergence or divergence. So when the lens lose the capacity of divergence and convergence, okay, then the rays of the light fall behind retina, causing hypermetropia. And if this hypermetropic condition is occurring because of the age-related condition, then we call it as a presbyopia. Okay, when there is nothing abnormal, it is just because of the age, because the lens is not able to converge it, then we call it presbyopia. And if it is not because of age, we call it hypermetropia, means far-sightedness. Okay, so far-sightedness can be, yes, number one, it can be why? It can be because of loss of convergence power, loss of convergence power of the lens and cornea, and number two, small eyeball. Small eyeballs. If this eyeball is small, due to genetic or environmental conditions, they can also have hypermetropia. Okay. Now, if you go to a doctor and he diagnoses hypermetropic, now what treatment he will give? obviously he will give something that is diverged, is converged here. So he will give convex lens. He will give convex lens, not concave here. He will give a convex lens, so that now instead of rays of light coming in, there is focusing more is coming, is converging, and then it is falling under one point. Okay, so treatment is of hypermetropia is convex lens. Okay. Now you see this cornea is very important, because cornea do the 75% bending of the light. Okay. Now sometimes when this curvature of the cornea is also altered. Okay. When the curvature of the cornea is altered, when the curvature of the lens is altered, and when the image is formed, one image is formed here, another image is formed here also, because of the loss of the curvature. Cornea is nicely curved. When it loses curvature, then the light is entering and scattered everywhere. When the ray of light is entering, it is scattered everywhere, and there might be two images formed, one at the retina, one is like a myopia. Okay, then when there is a two image kind of thing, blurred, okay, and it's distorted, we can say the image, final image, what you'll see a distorted image, half here, half of the body this way, then we call it a astigmatism. Astigmatism. So this is about the refractory errors. So when we say refractory errors, or it comes as shorter, you have to write myopia. You don't need to write a lot, you just draw the diagrams. Myopia, hypermetropia, presbyopia, astigmatism. Is it okay? Or do you want me to repeat something?
It's clear, sir.
Okay, thank you. Now I forgot to mention one more thing when we discuss the anatomy of the eyeball. There is some fluid inside the eyeballs. So let's discuss, there is some fluid inside also the eyeballs. So middle layer, we know the middle layer is choroid. This is choroid, ciliary body, and iris. And here is the lens. Now this is, what is here? There is some jelly kind of material. Okay, jelly kind of material. Okay, like if we have applied some hair gel, it's just like some that kind of material, some jelly kind of material here. So because of the presence of the jelly kind of material, it makes the eye distended. So what is the jelly called as? This is called as vitreous humor. Vitreous humor. Okay, so this vitreous humor makes this posterior chamber, this posterior, this space, it makes the eyeball distended. This jelly kind of thing, which is called as vitreous humor. In the front of the lens, there is another fluid. Okay. So here what is present? Another fluid, that is clear fluid is present, called aqueous humor. Aqueous humor. Okay. So aqueous humor, this is presented in both the chambers. So this is called, okay, let me zoom this part. Okay, I am only zooming this part so that we can have a clear knowledge now. So the aqueous humor is present here and vitreous humor is present at the back. Okay, I am just zooming this part. So this is the lens. This is iris. Okay. So aqueous humor is present. Where it is present? It is present here. It is present here. It is present here also. So this is called anterior chamber. What is the anterior chamber? Anterior chamber is the front of the iris, back of the cornea. This is called anterior chamber. Anterior chamber. And what is posterior chamber? Posterior chamber is the front of the lens. So this space, front of the lens and back of the iris. Okay. So aqueous humor is present in the posterior chamber and the anterior chamber. Right. Let me close it. Okay. Now question comes, where this aqueous humor comes from, where this liquid comes from. Okay. So we have to go to the irido. This is the iris, iridoscleral angle. Okay. This is the ciliary body. Okay. So ciliary body, iridociliary angle. Okay. This is iris and ciliary. So here, right here, there are some epithelial cells here. If you microscopically, if you zoom it, there are some epithelial cells. Behind these epithelial cells, there are blood vessels. There are blood vessels. So from these blood vessels, sodium, chloride, they move outside constantly. Okay, this pulls out this because of the sodium and chloride coming out of these blood vessels, coming out through this ciliary body. This is where we are locating at the ciliary body now. In this ciliary body, there in this corner, there are some cluster of blood vessels lying very close to this pigment to this epithelium. So this through this epithelium, what comes? Sodium comes, chloride comes, bicarbonate comes, and along with that, some important things come. That is ascorbic acid, that is vitamin C, ascorbic acid, ascorbate, some immunoglobulins, ascorbate, immunoglobulins. Okay, and what else? There can be some, yes, glucose. So ascorbate, immunoglobulins, glucose, some nutrition along with sodium, chloride, along with some 99% of water. With together this composition we call this aqueous humor. So what is aqueous humor is composed of? Composition of aqueous humor, 99% water, then rest of the 1% consists of electrolytes, sodium, chloride, bicarbonate, along with ascorbate, immunoglobulins, glucose, and other nutritions. So this aqueous fluor, why this aqueous humor is important? Because this aqueous humor is important in the sense, because of the presence of the fluid here, it keeps the eyeball distended. It keeps this part distended. If this fluid is not here, what will happen? The whole cornea will collapse. You might lose the vision. So we need a constant source of fluid which is present in this posterior chamber and anterior chamber, and as a result it keeps our eyeball distended. It keeps the cornea distended so that the rays of light can be refracted. Are you getting my point? If you don't understand, let me know. Okay. So now question is here. What is the question here? The question is that, so this aqueous humor, we need the aqueous humor, right? Why we need the aqueous humor? We need it to supply metabolites. We need it to wash out the waste products. For whom? Because this lens and this cornea, they are avascular structure. There is no blood supply to this lens and the cornea. They are avascular structure. So they need source of nutrition from outside. And when they eat, they have to secrete some waste products also. So this way, nutrition and taking out the waste products is done by the aqueous humor. That is number one function of aqueous humor. Second function is this aqueous humor keeps this posterior chamber and anterior chamber, fill up this posterior chamber and anterior chamber, and as a result it makes it distended. As a result our eyeball is round. Okay. Now third point to be noted here. The aqueous humor is constantly moving out. Remember, it's constantly moving out. Say around 1.3 microliter per minute. It's constantly moving out. Whereas this aqueous humor volume, how much is the volume? Very less, just 0.3 ml. So constantly the fluid is coming here, and still the volume is maintained at 0.3. Then where this fluid is going out? Where is this going out? So there must be some drainage channel. There must be some output channel, because fluid is constantly coming here from the both sides. Okay. So the thing that you need to understand, this fluid is coming this way, this way, this way. From the posterior chamber, it goes to the anterior chamber, anterior chamber, anterior chamber, anterior chamber, and it disappears here. And it disappears there. It's going out. So let's see how it disappears. Okay, so let's zoom this part. This is the iris. So it has been seen that here there is a hole. There is a hole here, which is called, there is a canal here. This is called as canal of Schlemm. Canal of Schlemm. So this canal of Schlemm is present in this junction. Okay, this is called canal of Schlemm. So when this aqueous humor comes from here, it goes from the posterior chamber between the lens and the iris and goes from here. And it has been also seen that in the front of this hole, front of this canal, there is another meshwork. There is a, like, you can see some like this front of the shower grills, there is some meshwork, like small, there is some meshwork. Okay, there is some kind of meshwork here. It is also present here. It's not just open up like this. There is also some meshwork, which is called as trabecular meshwork. Now this trabecular meshwork, it do offer some sort of resistance. It don't let that fluid is just coming in like this, like this, like this, and going out. It don't let it. It offers some resistance. It asks the fluid, stay back, you are not yet ready to go. So when there is enough fluid collected, then it let it go. So it maintains a constant pressure. It maintains a pressure. It maintains a pressure. This is called intraocular pressure. So that is the most important function of the aqueous humor, that it maintains the intraocular pressure, which is normally 10 to 21 millimeter of mercury. Normally it is 10 to 21 millimeter of mercury. So when you note the pressure of the eye, it is measured by one instrument called tachometer. So when it is measured that the pressure is high, like 25, 26, then we said increased intraocular pressure, most sometimes seen in headache and other diseases. Okay. Did you understood up to here? Any questions?
Yes, I understood.
Okay, thank you. Now let me block this thing. Okay, let me block this canal. Okay, let's block it. Let's block some. Let's put some stone here and block this canal. So I put some cement plaster, I block it. What will happen here? If I blocked it, I blocked the output, I blocked the drainage pipe. So now fluid is coming here constantly. Okay, fluid is coming here constantly. Let me complete this eyeball now. Okay, and these are the optic nerves. So fluid is coming here constantly, and fluid is not going out because of the blockage. So as a result, there is gradual increase in intraocular pressure. As a result, intraocular pressure is increasing, right? So when the pressure in the eye is increasing, what is it, how the patient will come? They'll complain of severe frontal headache. They'll complain of headache in the front, over the eyeballs. They'll complain of and frontal, and they can also complain of blurry of vision. And when they especially in the night, they see some halo. They see some halo around the image. Okay, they can have difficulty in vision, blurring of vision, and sometimes it may lead to loss of vision completely, complete blind. So this condition, when this intraocular pressure is increased, now what happens? Why is the problem? When the intraocular pressure is increased because of collection of the aqueous humor here, gradually it is giving pressure to the whole eyeball. It is giving pressure to the whole eyeball, and here there is the optic nerve. It is giving pressure, and as a result, optic nerve will be, there will be dent. There will be dent here in the optic nerve. We call that as a cupping. when it is seen in the ophthalmoscopy. And we call this condition as a, anyone can say what is this condition called as? This is called
glaucoma,
as,
sir.
yes, this is called as glaucoma. Okay, so when glaucoma happens to the patient, you have to know what is the problem here. Problem is there is the outflow block. As a result, intraocular pressure is increased. As the patient is complaining of headache, and sometimes they may become completely blind also. It is so dangerous, and we call that condition as a glaucoma. Okay, now a little bit more about glaucoma. It's so interesting. Okay, so glaucoma can be of two types. Glaucoma can be of two types. It can be open angle, or it can be a closed angle glaucoma. So it can be of two types: open angle glaucoma and closed angle glaucoma. So let's see what is open angle glaucoma first. Just a simplified diagram, okay. Let's. Now, what is open angle glaucoma? Yeah. Okay, wait. This is the zonules holding the lens. Okay, so here there is a hole and a trabecular meshwork. Okay. So open angle glaucoma means when the fluid is coming good from here, fluid is coming from the both sides, good for here. But this trabecular meshwork, remember there is trabecular meshwork. They are being blocked. It can happen in diabetes. It can happen in some many other diseases. Okay, I'm forgetting the causes. It can happen due to many other diseases when the trabecular meshwork is blocked. When there is a blockage in this trabecular meshwork. So as a result, now fluid is being collected here. Then we call this open angle glaucoma. Remember this open angle glaucoma, because of the trabecular meshwork blockage, it is always in chronic condition, and most of the time it is painless and it develops in years. Okay, it don't develop. Okay, and it develops in years, and it is mostly of the time painless. Okay, it is not painful like having severe headache and blindness like that. It develops in years. So when they go to doctors, they realize there is a glaucoma is there, and it is all the headaches, all the small things is because of the glaucoma, and this is open angle. There's one they remove this trabecular. They did operation and did trabecular meshectomy. We remove the trabecular meshwork. So another is closed angle glaucoma. Now what happens in closed angle glaucoma? So sometimes due to injury, due to infection, due to tumor, this iris is displaced. Okay, this iris is displaced. Now, this iris is displaced. Okay, this iris is displaced. So as a result, now fluid from here, they cannot move because this angle, this whole road is, okay. Let me make it clear here. Okay, this is the, okay. So now the fluid is coming here from the posterior chamber, and while going to anterior chamber, this is blocked because of the displacement of the iris. So this angle is blocked. That's why you call it closed angle glaucoma. It is because of infection, tumors, injury. Okay, when the iris is displaced, and it is blocking the angle. So as a result, fluid cannot come through it. It cannot reach the trabecular. So trabecular meshwork is okay, but the root is blocked by the displaced iris. So that we call closed angle glaucoma. And closed angle glaucoma develops in hours. It is sudden. Suddenly the patient becomes blind. He complains of headache, severe headache, painful, red eye, swollen eye, and he becomes blind. That is mostly closed angle glaucoma. It may be because of injury, infection, tumor, many other causes. Okay, and diabetes is also one of the causes here.